We want to thank you here at Educure nonprofit organization for joining us for our MS Matters Beyond the Diagnosis webinar. My name is Stephanie Sweat. I am the executive director here at Educure nonprofit organization. This month, we're highlighting MS, and tonight, our president, Dr. Emanuela Doe, will give a comprehensive overview of MS as well as the new medical advancements that are coming onto the market. Dr. Doe has over 10 years experience in clinical research. This presentation was brought to you by Dr. Emanuela Doe as well as our clinical science physician, Dr. Mariana Vasquez. First, before we go any further, we want to take some time and listen to a note from Dr. Doe that explains more as to what Educure nonprofit organization is.
So Educure nonprofit organization, like its name states, is a nonprofit organization that aims to be a bridge or a liaison between the community and the clinical research world. So from its mission statement, from awareness to access, from access to action, its goal is to make sure that through education and more of meeting with the underrepresented populations, we can address issues that have historically stopped populations from the underrepresented sections of it to join clinical trials and be a part of what is important for everybody. Clinical research is a part of healthcare. Clinical research is a branch of healthcare, although it's not known as, commonly as the part of healthcare that addresses, for example, health issues, diagnosis, medications. But clinical research is that part of healthcare that works with controlled research to develop healthcare products. What are healthcare products? Healthcare products will be things like new medications, new medical devices, and just anything new that we are bringing onto the market for human beings to have access to and use it for their health. Clinical research has to make sure that these are safe and effective. It's important to ensure that every population is fully represented when we are performing clinical trials, which are studies done through clinical research. All these different populations need to be represented so that we can assess not only the benefits of the product, but also the side effects and just how it affects everybody, so that we pretty much, before medication is approved by the FDA, found in the pharmacies, we can ensure that on this particular population, Hispanics, this is how it may react. On African Americans, this is how it may react. On Caucasians, and so on and so forth. So if underrepresentation is not addressed, then the results that are out there are not accurate. And it means a good amount of people will not benefit as they are supposed to, because the clinical trial wasn't done in a way that it addresses every population. Why is underrepresentation such an issue? So everybody is built differently. Everybody has a different genetic composition. However, if we are ethnically of the same race, we can have some compositions that may be similar to each other as compared to if we are different races. So genetically, we are different. That's a fact. So which means the way medications work on a particular group of people may not work in the same way. It's non-historical. Studies have shown that, for example, one of the multiple sclerosis, for example, African Americans were more severe in terms of like the side effects that were experienced were more severe than any other populations that were involved during that study. So that just entails that we are all genetically built differently, so we will react to medication products, even food, in a different manner.
Now we're going to ask Dr. Doe to present the presentation for the MS Beyond the Diagnosis webinar. Dr. Doe.
Thank you, Ms. Sweat, for the introduction. It's important to note that the whole Educure team worked very much to build this webinar for everybody. So we will jump into the presentation right now. All right, so welcome everyone. Welcome to MS Matters Beyond the Diagnosis. Thank you for joining us today. I would like by quickly starting this presentation with everyone imagining that somebody's brain and spinal cord are like your body's
center or central command system. So if you have your brain and your spinal cord, like let's say a high-tech building central command system, and your brain and spinal cord transmits messages or communicates with the other parts of your body through messages. And these messages go to the other parts of your body to actually enact an action or a command that was sent by the brain and the spinal cord. So you can somehow look at the human body like some type of an internal wiring system. So if, for example, the brain and the spinal cord communicates with the whole body through messages, messages go down through what we call nerve cells. Nerve cells send these messages, also called nerve signals, to the parts of the body where there is action. Now, what are the different commands that your brain and your spinal cord may ask you to do? It may ask you to pretty much move, like walk. It may ask in terms of like vision, in terms of memory, in terms of sensation. So there are different parts of the body and different systems that the brain and the spinal cord controls. And they control these different organs or different parts of the body through the signals that are messages that are being communicated by nerve cells. Now, let's go back to the scenario I was trying to create in everyone's head. Like if, for example, your brain and your spinal cord are, let's say, the central unit of a high-tech building, and they communicate through nerve cells, which could be looked as electrical wires. And these electrical wires, if everyone has that image in mind, the electrical wires are usually coated with a protective insulation so that it doesn't transmit carelessly the electricity that's passed through them. So imagine that nerve cells are also coated with an insulation. So we can compare electrical wires and nerve cells pretty much similarly. Now, if there is any damage in that high-tech building with electrical wires, what happens? The electrical conduction is also interrupted, or it can be interrupted in separate ways. It can be slowed down, it can be completely cut. And so there are just different ways that the signal will not reach to where it's supposed to go to effectuate the command. So in the case of multiple sclerosis, it's pretty much about the same way, which is there is damage to our body's internal wiring. And because there is damage to our body's internal wiring, the messages that are sent, the nerve signals or messages that are sent by the brain and the spinal cord to the organs will be interrupted, slowed, or delayed, or cut off completely, resulting in the different symptoms that we find in multiple sclerosis. And it's also important to know that this damage to our body's internal wiring, in the case of multiple sclerosis, is caused by the body itself. So the body will cause this damage because it attacks itself, damaging this protective insulation or protective coat that surrounds nerve cells, and so resulting in these issues in terms of nerve conduction. And so once this is done, that's why we can notice in multiple sclerosis, first of all, there are different symptoms. It could go all the way from difficulties walking, difficulties communicating, impaired vision, and it could go all the way from fatigue to numbness. So there are just different severities in terms of multiple sclerosis, and there are also in terms of symptoms of multiple sclerosis, and there are different symptoms which also vary with different individuals. So this explains a little bit, imagining again that there is an interruption at the level of this internal wiring. Depending on the level, the extent of the interruption, that will cause also the different variety in multiple sclerosis symptoms. So let's begin with the fundamentals. What is multiple sclerosis? Now let's talk about it in a scientific way. Multiple sclerosis is an autoimmune disease where the body mistakenly attacks the myelin sheath. So myelin, again, let me introduce it to everybody. Myelin is that protective insulation that wraps around the nerve cells. So again, as we can see in this in this slide, we notice that we have the colored sheet around the nerve cells. As you can see, the nerve cells will be the blue, indicated in blue. But again, we can notice that we have like a brownish pink layer around it. That's what we call myelin. Myelin is a protective insulation around nerve cells. So it doesn't only protect the nerve cells, but it also would help in the conduction of nerve signals. And how does it help in the conduction of nerve signals? It makes it faster. So it makes the signals go from the brain to the organ or the part of the body that the brain wants the action to be done faster and smooth. So it means if you want to walk, you walk in a smooth manner, like you walk smoothly, and it seems so effortless, is because we have not only the nerve cells, but also the myelin that makes sure that this nerve signal that was transmitted from the brain is transmitted in a smooth manner to have a smooth result or a smooth outcome. Okay, so now let's talk about the different types of multiple sclerosis. Again, multiple sclerosis isn't a one size fits all. There are different types, and we're going to talk a little bit about these different types. On the same slide, you can notice that we have our first type, which we'll call the CIS. CIS is a short form for clinically isolated syndrome. So in clinically isolated syndrome, multiple sclerosis subtype, there is a first episode. And once you have a first episode, what does that mean? We have a first pretty much symptoms of multiple sclerosis without the diagnosis yet. So there is a first episode, and then that first episode now might develop into multiple sclerosis. So clinically isolated syndrome is when we see a first episode that looks like an episode of multiple sclerosis, but we don't yet have the diagnosis, and it might develop into full-blown multiple sclerosis. The next type we're going to talk about is the also called RRMS, or relapse remitting multiple sclerosis. So relapse remitting multiple sclerosis is the most common type of multiple sclerosis. It is marked by relapses and remissions. And the next slide after this is going to explain a little bit more. We also have the secondary progressive multiple sclerosis. So usually the secondary progressive multiple sclerosis, also called SPMS, looks a lot like the RRMS in the beginning. So it looks a lot like the relapse remitting multiple sclerosis subtype in the beginning, but then it now begins to gradually worsen. So the difference between both of them, we will also emphasize that on the next slide. And finally, we have the PPMS, or primary progressive multiple sclerosis. So it simply means that it progresses from the start. So we have a patient with multiple sclerosis and the symptoms progress. It just starts, it starts from somewhere and it just worsens, like it just progresses from the beginning. So we will talk about these different types on the next slide to make it be a little bit more easy to assimilate. All right, so this is a figure that pretty much shows a little bit about what we're talking about on the first slide. Here we can notice the different types of multiple sclerosis, and we can notice because they are color coded, so we can also distinguish them based on the colors. So we're going to talk about the clinically isolated syndrome, which is designated in yellow. So as you see, it's yellow because it's pretty much an isolated episode. We have a first isolated episode, so it stands apart, and then it may or may not develop into multiple sclerosis as it is known. Then we have in green, the relapse remitting or relapsing remitting multiple sclerosis. And that, again, like I said earlier, is the most common multiple sclerosis. And as you see in green, in the green graph, we have like the zigzag pattern. So which means it's characterized by relapses and remitting. So on and off in terms of like the flare-outs of the multiple sclerosis. So a patient with relapsing, remitting multiple sclerosis will feel okay, will be pretty much back to a baseline, and then will experience an episode or a flare-out where we have like, acute symptoms of multiple sclerosis. And then we have back that rest that period of rest. So it's going to be an up and down pretty much way of presenting. So that's the relapsing remedy. Now, I will jump to the secondary progressive multiple sclerosis, which is in pink. And you notice it will start like the relapse remitting multiple sclerosis type. So you're going to have the zigzag, and then afterwards it goes by progressing. So, and finally, we have the primary progressive multiple sclerosis, which just starts and progresses from the start. And also, real quick, the primary progressive multiple sclerosis will be in pink, and the secondary progressive multiple sclerosis will be in orange. All right. Okay, so here we can see pretty much an image of a healthy neuron or nerve cell as compared to one that has been damaged. So if we imagine the brain trying to send messages through a nerve cell, and that message is being helped by myelin or the protective insulation that we can see in brownish pink. You can just imagine on the healthy neuron is going to travel faster and smooth because it's all coated by myelin sheath. But however, on the damaged neuron that you see right next to the healthy neuron, you see that the myelin sheath is interrupted at several levels on the same nerve cell or neuron. And so because of this interruption, the signal as well will be interrupted, or based on how severe the multiple sclerosis is, the signal might be interrupted also. All right, so what are the risk factors for multiple sclerosis? So multiple sclerosis is it's a complex medical condition, and it tends to show up between the ages of 20 and 50. So it tends to pretty much present itself at that time in individuals that are affected by it. So women, based on studies and on history of multiple sclerosis, women tend to have more of the condition as compared to the men or male sex. All right. Now, also having a female history and also being exposed to a virus called the Epstein-Barr virus, or EBV for short, and low vitamin D levels have been pretty much sorted out as some reasons or some risk factors with multiple sclerosis. So people who tend to fall within these risk factors also tend to develop multiple sclerosis, as it has been seen in studies. Understanding these risk factors is very important because it helps us to, first of all, one, recognize when the disease might show up, and not only recognize, to intervene when there are episodes of multiple sclerosis. Now, so this video actually shows, gives a more scientific look of what happens within the body. So again, we can see how the nerve signal, which is the little red light that is traveling across this nerve cell, again, first of all, it started off by being yellow, and then when it comes to the damaged part, we have like a loss in that signal. So that's exactly what happens in multiple sclerosis. Multiple sclerosis involves inflammation. So it's gonna first of all start with an inflammation of the nerve cell. And once there is that inflammation caused by the body will cause that destruction of the myelin protective insulation, which will result in the loss of the myelin sheath that covers, or another word for that loss or destruction of myelin is called demyelination. And finally, it could result in neuron or nerve cell loss completely. So again, we're going to break down this process in this webinar today, and we want to explain this complex process in a patient-friendly way so that everyone can understand in simple terms what multiple sclerosis, especially its pathophysiology, is all about. All right, awesome. So again, talking about its pathophysiology, we can see right here that, again, as multiple sclerosis, we have triggers. We spoke about the different risk factors that could lead to that exposure, but not only the presence of the risk factors, but also the trigger. So again, if you think about it like an allergy, like for you to have an allergy reaction, you have to be placed in front of the allergy or the pretty much the cause agent or whatever causes the allergic reaction from you. So that's exactly what we call MS triggers. So they are triggers that will cause this startup and this your immune system to be triggered, and your immune system is also going to react to these MS triggers that will cause this your body or the immune system of the body to react. So the immune system of the body is going to react in a way that it's trying to fight pretty much an invader or a foreign invader, and because it's reacting, is going to activate immune cells. We will talk about some of them as we break down more medications as we go. But when we talk about immune cells, we talk about lymphocytes, we talk about B and T lymphocytes, we talk about just different types of immune cells, microglia, and all of that. So once we have this activation of these immune cells by the immune system, these immune cells will now uncontrollably attack some parts of the brain, so causing that inflammation. So once it goes to attack, in this case, not foreign invaders, it will attack some parts of the brain, which it has mistakenly confused as a foreign invader. So it will attack that part of it, causing that dysfunction or inflammation, which causes the dysfunction and now destruction of these nerve cells by destroying the myelin first. So once we have, again, I'm going to take a step back just to repeat it so everybody can understand. We have MS triggers, which will trigger your immune system. Your immune system is going to react in lieu of pretty much looking for a foreign invader, but there is no foreign invader. So it's going to react, activating immune cells, which could be lymphocytes, B lymphocytes, T lymphocytes, and other types of immune cells. And this will cause an inflammation. So it will go attack the nerve cells, destroying it by causing an inflammation. And because of this inflammation, we have destruction of the myelin sheath around the nerve cells, and thereby destroying the nerve cells, which will now result in an interruption or delay or slowdown in the nerve signals to that part of your body, and thereby causing all the symptoms or most of the symptoms that we see in multiple sclerosis. So multiple sclerosis, as if you guys are already catching onto the train I'm trying to pull, multiple sclerosis symptoms will vary very widely because, again, like I mentioned in the first slide, it will attack different parts of the nerve cell. And because it attacks different parts of the nerve cell, so different levels of attack, different severity in the terms of attack, will cause symptoms to vary very widely. So some people may feel that they are extremely tired or some fatigue. Some people will have vision problems, difficulties walking, or even coordinating their walk. Some people will have, like you guys see in the presentation, will have like muscle spasms. We will have numbness, weakness. Again, we can also have some other symptoms, which most people are not sure if it kind of aligns with multiple sclerosis. But once you understand how multiple sclerosis functions, and especially in terms of the damage, you can start seeing pretty much the link between all of these symptoms. We have things like speech disturbance. We can also have cognitive issues, so memory issues. Depression might be part of it. Bladder issues, so we can have not only the bladder, but also in terms of like fecal incontinence. We can also have sexual dysfunction, and some of the symptoms might also look like pain. So, all right. So let's jump on to diagnosis. So how is the diagnosis of multiple sclerosis done? So the diagnosis for multiple sclerosis is at different steps, or what we call a multi-step diagnosis. It involves not only neurological exams, it also involves MRI scans or magnetic resonance imaging scans. Sometimes we can also step into lumbar punctures, also called spinal taps, and also a lot of tests to pretty much test the nerve responses. However, doctors have also worked on what we call the McDonough criteria, which helps to confirm multiple sclerosis. And the McDonald criteria, pretty much for diagnosing multiple sclerosis, is based on different indicators or different information gathered together. We have one which will focus on dissemination in space. What does that mean? Multiple areas of the brain and the spinal cord are affected. So what do we mean by multiple areas of the brain and spinal cord are affected? We'll look at the MRIs and we'll discover if we have multiple lesions in terms of like the brain and the spine or the spinal cord. We also have dissemination in time, which is the second modality. And that means damage has occurred at different points in time. So again, the McDonough criteria can be a little bit more complex for non-medical personnel, but in terms of how doctors use it, it has been used to confirm multiple sclerosis using the pretty much the alliance between MRI scans and lumbar punctures and also a review of symptoms and of course the neurological exam. So this whole package allows for an earlier diagnosis and a timely treatment. So now talking about timely treatment. So let's talk about current treatment categories for multiple sclerosis. So we can group treatment in 4 areas. So let's group them in 4 separate areas. We have the first area that are disease modifying therapies or DMTs. So DMTs work by targeting and limiting so they work by targeting and limiting the activity of certain immune cells. So specifically, I spoke about lymphocytes T and B lymphocytes earlier. So the DMTs would target activated T and B lymphocytes. And these T and B lymphocytes, obviously, in terms of multiple sclerosis, they are thought to attack mistakenly the protective layers of protective sheet around nerve cells called myelin. And so the DMTs will help pretty much to manage relapses, relieve symptoms because of that particular approach towards, pretty much curing multiple sclerosis. So that's for DMTs. Once we're talking about if DMTs don't work, we can also look at plasma exchange and steroids. So steroids will usually be used in terms of reducing the inflammation that is done during or pretty much present during multiple sclerosis flare-ups. So we're going to talk about that in the next slide. And in terms of like, there's also symptoms management. So which means multiple sclerosis symptoms are managed using certain medications like we see baclofen, amantadine, and some other medications are used to manage symptoms. And we also have some medications and some therapies that are used in terms of rehabilitation. So most multiple sclerosis patients lost pretty much their ability to walk, and or some of them walk with difficulties, or some of them use actually assisted devices to help them in walking. So physical therapy, occupational therapy will usually help in to rehabilitate such patients. And also in terms of lifestyle changes, we also talk about that in the upcoming slides. And finally, vitamin D has been noted to help also in terms of like rehabilitating multiple sclerosis patients. All right, so now talking about different cares, especially in terms of different standard of care based on different subtypes of multiple sclerosis. Again, CIS, which clinically isolated syndrome, often calls for early DMTs. So we spoke about DMTs earlier, disease modifying therapies, also known as DMTs. So in terms of CSI, we have some patients have been given DMTs and they have been noted to help. Also, in terms of RRMS, there are RRMS, since that is the most common, multiple sclerosis, there are a widest range of therapies available for patients that have RRMS. And so they can range all the way from injectables to orals to infusions, and we will break that down as we go. We also have SPMS, and we have medications like siponimod that is also pretty much used a lot for patients who present with SPMS. Or if not siponimod, we also have the symptom-focused approach, which means the management of symptoms for patients. And finally, in PPMS, patients have been given ocrelizumab and also some supportive strategies. So all this represents the current standard of care in terms of multiple sclerosis subtypes. Now, acute treatment. So what happens during flare-ups, as they call? So multiple sclerosis patients will refer to their acute episodes as flare-ups for some of them. And so in hospitals, corticosteroids have been given because corticosteroids have been found to reduce the inflammation that are caused by these immune cells onto patients. But if that doesn't work, plasma exchange also has been found to help in terms of patients. So pretty much in terms of corticosteroids, patients can be given corticosteroids orally. For example, the most common one is prednisone. They can also be given by IV or infusions, and also that particular type is also prednisolone, that has been given in order to alleviate the inflammation that is caused during multiple sclerosis. Now, in terms of symptom management, again, we mentioned earlier baclofen and some other medications. So we have some spasticity that has been noted. Patients will complain of having muscle spasms. And so in hospitals right now, they have been treated with baclofen, tizanidine, and we have cyclobenzaprines, and also Botox has been found to help. In terms of fatigue, patients have been given amantadine, they've been given modafinil, and just some other types of medications, including some antidepressants have been noted to help with the fatigue symptoms that most of the multiple sclerosis patients are experiencing. Now, some patients also experience a decrease in their walking speed. And so some medications like Ampere has been given to help alleviate that particular symptom, but it doesn't work for all patients. Notably, patients that have kidney issues or seizures have not been given that medication because that's not safe for them. And so we have other symptoms also. I've discussed it a little bit, earlier in other slides. And so some patients are given medications for depression. Some patients are given medications for pain, bladder and bowel issues. And also in terms of like their sexual dysfunction, there have been some treatments around those symptoms so that can help the patient regain a certain level of normalcy. All right, now we spoke about lifestyle measures also. So patients have been encouraged or are being encouraged to pretty much exercise and do yoga. So just some different lifestyle and alternative therapies have been found to pretty much help in terms of multiple sclerosis symptoms in the different subtypes. And so diets like, for example, the Mediterranean diets and also complement traditional treatment have been found to help also. We also spoke about vitamin D earlier. So yes, vitamin D3 given in a specific manner have also been found to help regulate the immune system. And some other patients are being given cannabis extracts, especially the oral cannabis extracts, which have been found to help in terms of reducing muscle pains and muscle spasms. So this has shown some promising results to help patients with multiple sclerosis symptoms. All right, so that's what's happening right now. Now let's focus on what's happening pretty much in terms of clinical research and multiple sclerosis. So again, it's important to note that every approved medication once began as an experimental idea, And that experimental idea was passed through clinical research before, and it was tested through a trial before it became the medication that is currently prescribed in the hospital and found in the pharmacies. So it's important to note that. So we are entering an exciting chapter, which is looking at innovation. So we will talk about emerging therapies, looking at those pretty much that are standing out from 2025 and beyond. Obviously, these medications have been tested over the years, and it's been years of testing, but now we're getting to a level where they are standing out and interesting enough for us to have a discussion about during this webinar. So we will start with frexalimab. Frexalimab represents the next generation monoclonal antibody. And so it has promising relapse reduction in terms of what's happening in studies. So let's focus on the studies with frexalimab. So studies with frexalimab have shown that unlike traditional multiple sclerosis medications, these traditional multiple sclerosis medications have a common side effect, which is it lowers the entire immune system and therefore can make patients more prone to infections. So frexalimab, on the contrary, works on a specific type or a specific part of the immune system. So this specific part of the immune system that frexalimab works on is a protein called the CD40L. So that protein has been studied and found to be involved in multiple sclerosis inflammation. And therefore, since frexalimab works pretty much by inhibiting that protein in particular, it helps reducing relapses without affecting the entire immune system, which could be the reason why with frexalimab, there are lesser side effects recorded on the studies that have been involving that medication. All right. The next medication I'll talk about is Bruton tyrosine kinase inhibitors, and it's also commonly known as BTK inhibitors. BTK inhibitors have been spoken more about in cancer therapy or cancer therapy management or treatment. However, BTK, I'd like to talk about it a little bit. BTK is a protein, and it's a protein that is involved in certain immune cells. So in the activation of certain immune cells, for example, B cells and microglia. So BTK has been linked to those immune cells. So these proteins can contribute to the inflammation that damages nerves in multiple sclerosis. Therefore, BTK inhibitors will aim to block this BTK protein, which may help in turn reduce disease activity in both the relapsing and the progressive forms of multiple sclerosis. So RRMS and PPMS or SPMS. So BTK inhibitors like frexalimab will also work on a specific part of the immune system, and thereby it will not unlike traditional multiple sclerosis medications that are already approved, it does not entire the whole immune system. So it works a little bit like frexalimab in that realm by just targeting a specific part of the immune system and still being promising in that target or that specific area. All right, so I want to talk about inverse vaccines, but imagine if you could retrain your whole immune system or retrain the whole immune system of a multiple sclerosis patient to stop attacking myelin. So inverse vaccines is pretty much unlike our traditional vaccines that are trained to attack foreign invaders. Inverse vaccines aim to retrain, so they aim to teach the immune system to tolerate the patient's body. So that's really a game changer. So in terms of stem cell therapies, particularly hematopoietic stem cell transplantations, so HSCT, that would involve resetting the whole immune system by using the patient's own stem cells. So we use the patient's own stem cells to reset the entire immune system, and by this process, to retrain the immune system to be hopefully less aggressive. Again, as it sounds, it's very intensive in terms of it's an intensive treatment, but the goal is to wipe out all the misbehaving immune cells and infuse stem cells that will help rebuild the new immune system that will be hopefully less aggressive. So again, this approach is not for everybody. And again, it's complex and it carries risks, but it is shown to help people who have real aggressive forms of multiple sclerosis. So again, the goal of the stem cell therapies, it is also to reduce the relapses and also to regain nerve function, which is a serious game changer in this slide. So the next we'll talk about remyelinating agents or remyelination agents. Their goal is to reverse the damage that has been caused by immune cells, especially in terms of regrowth of myelin. So we spoke about myelin at several levels. Myelin is that protective layer which is around the nerve cells. So remyelination agents, their goal is to regrow myelin and thereby restoring a better nerve function and potentially reversing some disability which is in MS, which is caused or found in MS patients. So these are experimental therapies that are focusing on repairing the damage that is caused by multiple sclerosis. And I just want to take a moment to say here that this is no longer science fiction. This is what's happening actively in trials today. So innovation has reached to that point where ideas are actually already implemented. And that's a game changer in terms of multiple sclerosis. Now, talking about clinical trials today. So clinical trials, compared to in the past, is no longer a one-size-fits-all situation. Like we just have one trial for multiple sclerosis patients. No. Now we have several trials that are crafted for each subtype of multiple sclerosis. Now we have RRMS trials that would include medications like orelabrutinib, and orelabrutinib is a BTK inhibitor. And so we also have medications like the PIPE 307 that is being explored. PIPE 307 is being explored due to its regrowth potential of myelin. So it's being explored because it can regrow myelin. So we also have in SPMS trials, we have medications like clemastine, and clemastine is an histamine drug. So an antihistamine drug could be like an anti-allergy medication. That's exactly what that looks like. We have medications that we get over the counter, and we get them for common colds, for allergies, flare-outs, and all of that. So clemastine is actually the same class of medication, but it's been studied because of its remyelination potential, so regrowth of myelin as well. In PPMS trials, we are looking at high-dose biotin, and high-dose biotin is investigated as well because it promotes myelin repair. So it's not regrowth, but a reparation of myelin. So it fixes myelin. And how does it do that? By pretty much, it somehow affects the enzymes that are involved in myelin synthesis. We also have stem cells approaches that I discussed earlier in terms of resetting the whole immune system by using the patient's own stem cells. All right, so these trials, again, reflect a strong move towards innovation and a more individualized approach and care in multiple sclerosis. All right, so we wanted to also create slides that will talk about, that will have an overview of the current standard of care and emerging therapies. So we will start with the RRMS or relapse remitting multiple sclerosis subtype, and we will look at frexalimab and teriflunomide. So again, we spoke about frexalimab earlier, which is a newer therapy that works by targeting CD40L protein, and the goal is to calm the immune system overactivity. So the overactivity of the immune system, the goal for frexalimab is to calm it down. And so frexalimab has shown promising safety results and also reduced relapse rates. Now, teriflunomide is what is currently FDA approved and the commonly widely used FDA approved treatment for RRMS forms. And also it involves reducing relapses as well. So teriflunomide is considered a disease-modifying therapy, as I discussed earlier. And so it will target and limit the activity of activated T and B lymphocytes. However, the issue with teriflunomide is because it targets T and B lymphocytes, it usually will cause an overall entire immune system weakening, as compared to frexalimab that focuses on only the protein, the CD40L protein, and so we'll work on that specific part of the immune system, thereby having lesser side effects in comparison. All right, so again, teriflunomide has proven to pretty much, again, like I mentioned earlier, reduce the MS relapses, but also it slows down the progression of disability over time. So again, frexalimab has some mild effects, which can also be some low infection. As we go, teriflunomide has been characterized by gastrointestinal side effects, headaches, alopecia, which is the loss of hair, and also some different other types of side effects. But it's exciting to see that we have such options and more options developing in terms of our MS subtype multiple sclerosis. Okay, again, focusing on RRMS, again, as I mentioned earlier, it's the most common type, and so the most studied type so far. So we have medications like the ocrelizumab, which we discussed earlier. Ocrelizumab is an FDA-approved monoclonal antibody treatment. It's not only prescribed in RRMS, but it's also prescribed in PPMS, so primary progressive multiple sclerosis. So how does it work? Ocrelizumab would work by depleting B cells. So B cells are also immune cells, which are thought to be involved in the damage or the inflammation that damages nerve cells. So it will work by depleting B cells, which slows the progression of the multiple sclerosis disability and also reduces relapse. We will look at orelabrutinib, which is a BTK inhibitor that is also being looked into for RRMS in trials. And so orelabrutinib is still investigational, but it's a BTK inhibitor, which means it blocks the BTK protein, which is involved in B cell signaling without depleting the B cell. So again, we can see the difference here, which is ocrelizumab will deplete B cells, so reduce B cells, reduce them in number, which will weaken the entire immune system, as compared to orelabrutinib, which will only work on a specific part of the immune system, which is blocking the B cell signaling without depleting it completely. And thereby, we have studies that have shown that orelabrutinib had 92% fewer new lesions in terms of the patients as compared to older treatments. So that is a potential game changer. Orelabrutinib is a medication to watch and a potential game changer. So in terms of SPMS, again, we spoke about siponimod. That is a current medication that is used in the treatment for multiple sclerosis, especially in patients that have SPMS subtype. And so how does it work? Siponimod works by sequestering lymphocytes, which are immune cells as well. And immune cells, as you guys have noticed in terms of multiple sclerosis, these immune cells attack the body, and so they attack the nerve cell, destroying myelin. Uh, and so siponimod will work by sequestering these lymphocytes and thereby slowing disease activity in this progressive multiple sclerosis subtype. And clemastine, which is originally an antihistamine drug, so also looked as like this anti-allergies, that's over-the-counter medication, is being studied because it can repair damaged myelin. So this is a nice overview and a nice comparison because we can notice that the medications now, there is a shift from creating medications that control inflammation only to medications that potentially restore nerve function. So if clemastine is proven to be effective, then it could offer a new kind of hope for SPMS patients. All right, and we will look at PPMS. So historically, PPMS or primary progressive multiple sclerosis has had fewer treatment options because of just how aggressive that multiple sclerosis subtype is. Ocrelizumab is currently the only approved FDA medications and disease-modifying therapy for PPMS. So again, as I mentioned earlier, it will work by depleting B cells and thereby reducing relapses. In cases of RRMS or in cases of PPMS, it will slow down the progression of the disease. But it's also high-dose biotin is under investigation as a nutritional approach to improve energy production and myelin repair. So while its results have been mixed, it underscores the need for diverse approaches to treat progressive disease, especially the progressive type of multiple sclerosis. So why clinical research? So clinical research is about advancing care. It's not just about managing a disease, and in this case, not just about managing multiple sclerosis, but moving towards a cure. So again, every single participant, past, present, and future, helps to push the needle forward. And so clinical research is more just than data collection. It's way more than that. It's actually the heartbeat of progress in terms of treatment and of progress in terms of multiple sclerosis treatment. So and I want to just recall this, every approved medication once began as an experimental idea that was tested through trials. And by participating in a clinical trial, patients who do not have access to treatments have access to potentially new treatments, but at the same time, there is also that contribution towards a larger story in terms of multiple sclerosis care and evolution. So again, participating in a clinical trial is one of the most direct ways that a patient can help themselves and also help others and help pretty much the whole multiple sclerosis community. Additionally, it's important to note that there is intensive medical oversight found in clinical trials. Clinical trials are pretty much conducted by specialized physicians, specialized healthcare providers with a well-trained team to make sure that every single aspect of the trial goes according to the well-crafted protocol that has gone through multiple screens and studies and even ethical bodies before it's been implemented on humans. So it's also important to note that there is a serious or intensive involvement of the FDA in terms of control in clinical trials. So why now? There's never been a better time to get involved in clinical research. Science is on the brink of major discoveries. As you guys have noticed from the medications like emerging therapies, we are not only talking about things that were designed and crafted in science fiction movies. These are things that are happening right now. These are things that are in trials. These are medications that are being studied and that have been used on humans, are being trying to change multiple sclerosis world. So we are getting to the point where we are at the brink of major discoveries. We are closer than we have been years ago in terms of multiple sclerosis advance and innovation and therapies. And so a patient's voice or your voice and participation can drive that momentum. All right. And how does it help? It does not only help in terms of like helping the patient, but it also helps in deepening our understanding of multiple sclerosis. Again, just referring back to what we've presented today, we've seen medications that control inflammation because that was what has been pretty much studied for over the years. But now we are getting to medications that can rebuild the immune system, reset the immune system, rebuild myelin, repair myelin that has been damaged. So we are discovering that this innovation is becoming more individualized and also smarter in terms of assisting multiple sclerosis patients. Okay, so for those who are interested, we have also crafted this slide up, which is a slide that has patient resources. And so if patients, participants, loved ones around a patient, like caregivers, are interested in learning more and just understanding what is multiple sclerosis and what is being done, or they are trying to get more involved with multiple sclerosis, this is a slide that is about trusted sources, where we have patient resources. So we have clinicaltrials.gov, we have the National Multiple Sclerosis Society that we have linked in this slide, and we have, as you guys have noticed, we have hyperlinks also present, and we have the MSAA, which is the Multiple Sclerosis Association of America. And these organizations will provide support, information, and access to trials, including Educure. We will also help provide access to more learning opportunities about multiple sclerosis, and also more about how to access these trials that could help the MS patient, and also a caregiver can help their loved ones suffering from MS. All right, and just to give a note and a shout out to all of our resources, these are the references we have used today, and all this information has been drawn from reputable sources. We have the Mayo Clinic, National Multiple Sclerosis Society, peer-reviewed journals, and current clinical trial databases. So we have two slides that show all the references where we have drawn information to craft our presentation for MS Matters Beyond the Diagnosis today. All right, so thank you again, everybody, for listening to this presentation. We hope it was very clear and concise and it pretty much makes everyone to understand that multiple sclerosis is challenging, but there is hope, there is support, and there is a path forward. And I'm going to now pass on the mic back to Ms. Sweat for her to continue with the closing part of this webinar. Thank you.
We want to thank you again, Dr. Doe. That was a very, very good and comprehensive information about what the future is to be expected with MS, as well as what current treatments are happening now. If you're interested, Dr. Doe brought out, you are more than welcome to contact us via email, whether that's at info@educure.now.org, or you can simply reach us by telephone at 833-428-7348. And again, as Dr. Doe pointed out, we're advocates for anyone that's interested in learning more about clinical research. Educure nonprofit organization again wants to thank you for joining us, and may all go well with you. Good night.